Good morning and welcome to this excellent ICU DDR webinar. I shouldn't say morning because some parts of the world it's not morning. Good day to everyone. I'm Carrie Hopkins-Isles, the Deputy Director for ICU DDR, and I'm so excited about our presentation today. Let me just take a moment to let you know that we have our conference, our virtual conference coming up. It is July 13th through the 15th, and you can go to icuddr.org to check out all the information. You'll register for individual sessions, so if you want to come to part of it or all of it. We also will have some amazing video poster presentations, so adapting to the new situations as they unfold here. And I have the pleasure today to introduce Todd Molefenter, and he is the co-director of the Center for Health Enhancement Systems Studies, so I guess that's CHESS, I like that acronym, and the director of the Great Lakes ATTC, MHTTC, and PTTC. We love our acronyms, don't we? Workforce Development Centers. He currently has 3 multi-site implementation science research grants. He's the co-PI for the Justice Community Opioid Innovation Network's Dissemination and Implementation Core, and a senior scientist at CHESS at the University of Washington-Madison. He spent the last 25 years leading and studying performance improvement in health systems, and we're glad that you'll be talking about that today. We haven't had any other webinars on this subject, so we're really excited for that. And just to let people know who are entering now, we're going to encourage you to put any questions you have in the chat box, and I'll be monitoring that throughout Todd's presentation. So if we have a clarification, something that I need to stop him and let him know that there's a question, I'll do that. Otherwise, we'll leave some time at the end and we can have a discussion. So thank you.
Okay. All right, welcome and good morning to everyone. I'm going to go ahead and share my screen while we'll go through that activity, and then we'll get started. All righty. Okay, good morning, everyone. It's talking to you from Madison, Wisconsin, here in the United States. You can tell by my background, we're due to COVID-related items, we're still working from home. For those of us at the University of Wisconsin, and actually, but most of the universities are working at home at this point still, and starting to gradually open up some of our restaurants and things like that. But still a COVID situation here, which I suspect is the way it is for a lot of you as well. And really excited about. I was really glad when IUCDR asked me to speak on this subject of implementation science, and it's something that I really have a deep passion for. There's a big need for, and to be able to do it with an international audience is really exciting. So let's get into the talk. Okay, great. And today we're going to talk about implementation science. We're going to have a focus on addiction and criminal justice settings, which I assume is of interest to most, if not all of you. And if you're just here for the implementation science piece, there's going to be some good things around that as well. And in just a brief background on implementation science, it's it's implied in the title of the talk. Is it's really this science where started in earnest 15-20 years ago with researchers saying, hey, we're doing a great job of developing this research, but we're having a lot of challenges and difficulties in getting it into practice. And so it started with that we have a big conference here in the United States now on dissemination and implementation, happens every December in Washington, D.C. And that started about 10 years ago. And I think they might have had 100 or 2 there. And now it's, well over probably I think 2,000 or 3,000 at this point. So it's really grown quite a bit as a field, and there's been a lot discovered and learned, and there's a lot more to learn. So let's get into that. So where are we as an implementation science field? I think we have a few things we can talk about. I mean, first of all, it's really needed throughout healthcare, and really in with criminal justice populations is no different. There's particularly in the addiction space, there's as I'm going to talk about here in a little bit, there's a lot of need, a lot of opportunity. And so I think this is a tool, a science, a technique, if to put it that way, that's really needed in this space. Implementation science itself, I'm mentioning a lot has happened around it, particularly over the last 10 years, but it is evolving pretty quickly if you look at other research fields, and really its history is really somewhat recent compared to other research fields. And right now, I would, as someone who's in the middle of all that and can brag about it on one side, on another, not so much. I think we're, as a field, we're stuck in what I'm calling typology frameworks, where you can characterize things. And we're not doing as much around performance improvements as I'd like to see. I think that the typology piece, we're going to talk about that today. I think it's really important. I think it's, as they would say, sometimes the term, it's necessary, but not sufficient, is definitely the case. I think it's really important that we understand how to classify things so we can communicate what we're doing. But we really want to do some more performance improvement kind of things. That's the whole purpose of the field. And we're going to talk about that too, and some of the research we've done here at the University of Wisconsin. The presentation will primarily be focused on opioid use disorders, MOUD, even medications for opioid use disorders in criminal justice populations. Okay, so let's talk about criminal justice populations just a little bit. Why implementation science is important here, as it is in all other populations, but in particular here, justice-involved individuals are 400 times more likely to use opioids and or painkillers than the general population. Pretty big statistic. And by the way, as I'm going through this, at the end, I have the reference list, and the slides will be made available if you're interested in any of the citations. Justice-referred patients are 1/10 as likely to receive agonist MOUD as other patients. And so we have a group that's 400 times more likely to receive opioids, and then 1/10 is likely to receive treatment. So pretty big disparity there. In addition, inmates' risk of deaths within the first 2 weeks of release is more than 12 times that of other individuals. This is research that's from 2007, and we now, with the opioid epidemic here, we have lots of other examples of that, not just with opioid use disorders and substance use disorders, but also suicide too. I was watching a recent research on that about a month ago, that people who are released from prison are 5 times as likely to commit suicide within the first 2 weeks. So there's just it's really a high risk area. And of course, with opioids, people are in prison, their resistance is down, and when they come out and use opioids, and particularly if they use it at similar levels as before they went in to incarceration, they're at severe risk. So because of these issues, we really are trying to get more the evidence-based practice we're trying to implement is medications, and there's just some tremendous opportunities there. I mean, the data is very strong on the benefits of medications, particularly methadone, buprenorphine, and extended release naltrexone, or as the trade name here in the States is Vivitrol. And and from a variety of reasons, when people are entering criminal justice settings, it helps with withdrawals. And more importantly, not more importantly, but as also important is as they're leaving criminal justice settings, being on some kind of one of these three medications can make a very large difference. Extended release naltrexone, research that Lee published in 2015 shows that people who have a shot, and the way extended release naltrexone works, it's an injection. It lasts for 30 days, and it prevents any effects from opioids. And you can see there's some improvement there with people receiving injectable naltrexone. There's also buprenorphine, which is more of a daily medication, although there is an injectable form of that available. And you can see here people start buprenorphine in prison settings that their treatment and their stay in treatment are much greater. And then lastly, methadone. People who are involved with methadone, you can see here the results are actually pretty dramatic. And so this is like a perfect issue for implementation science. It's like, wow, we have people who come in that have 400 times the likelihood and risk. We have 1/10 of the treatment in the general population, and in the general population there isn't enough of MOUD being prescribed and used. And so this creates a really a great opportunity for implementation science, is to try to figure out how to get these MOUDs implemented more. So let's talk about that issue and talk about it in the framework of implementation science. So with different typologies, as I called them earlier, or classifications, or there's different names you can give them. There's two I'm going to talk about today that here in the States, and particularly in the criminal justice settings, that have been pretty prevalent. The first is what we call tongue-in-cheek the ERIC strategies, and expert recommendations for implementing change. Excuse me. This is really a seminal work that was published in 2015 in implementation science. And what they did is, with this group of experts, excuse me, is they developed 73 strategies. And here on the screen, you can see some of them, of access to new funding, alter incentive, allowance structures, assess for readiness, audit and provide feedback. And there's a whole group of them. You can see what they did a good job of, and you have to be sensitive to, is they really looked at different levels. They looked at, okay, if you're actually within a jail or a treatment setting, doing something like building a coalition or audit and provide feedback could be something that would be a good strategy. If you work for a payer or a government, providing access to new funding could be a good strategy there. So the tool, you have to be a little careful on that, which level you're at, which kinds of strategies make the most sense. With the tool, I think there's things that are good about it is it's very good for what I call cataloging. We have a project now where we're a national project I'm going to talk about here in a little bit, where we have 12 or research studies that are looking at implementation science issues, and we're using these ERIC strategies to sort of describe what each of the study sites are doing. So it's very good with that. Even though there's 73, sometimes you have to create new strategies. For instance, a lot of the implementation science approaches that we use at the University of Wisconsin involve local change teams, and that's not one of the categories. But they covered most of it. It was work well done. And then also what we have found is we're trying to do this cataloging is it's easy to sort of fall into the situation where it's like, well, there's of these 73, we need to check as many of these as possible. And then it gets a little overwhelming for the person who follows that wants to say, okay, what exactly are these people doing? And so what we've really found is, trying to select the most, the impactful strategies, the ones you're primarily working on is the most helpful. So let's look. So like I said, I've been involved with a national effort for the past year, sort of looking at different implementation approaches in the criminal justice settings that are just starting. We have this large effort here in the United States looking at fostering MAT use in justice populations through something called NJCOIN. And it's part of HEAL, which I throw a few acronyms at you, but HEAL is a NIDA initiative, National Institutes of Drug Abuse, that's looking at different approaches to reducing the effect of the opioid epidemic here in the United States. And one is around criminal justice populations, another is around doing intensive work and in a few states here. And with the effort I've been involved with, NJCOIN, it's the acronym stands for Justice Community Opioid Innovation Network. It was launched, just not even a year ago, and what's really neat about it is there are 12 different research studies that are happening. About 7 or 8 of them are specifically focused on the issue of implementation science, and in particular looking at bridging of looking at when people leave incarceration, do they make it to treatment and receive MOUD or MAT? So where it's a pretty big effort. And what's nice about it is, and this is just sort of what all the pieces are. What's nice about it is it's giving us a chance to sort of, when you look at, and really when you're involved with this, and I'm admittedly somewhat new to the criminal justice community. If you look at the researchers involved here in the States, it is a bit of the who's and involved with it. Josh Lee, Peter Friedman, folks like that. And so it's been really, it's a great opportunity just to see what some of the more current practice is, and to learn how all that sort of comes together and informs where things are with implementation science, and just with the implementation of MOUD or MAT. And what all this busy chart says is, in the middle is the research hubs. We're going to talk about a little bit about what they're doing. We do have a coordination center. Earlier, in the introduction, I'm one of the co-chairs of the Dissemination and Stakeholder Core, and then there's also a group collecting data around this, the Methodology and Advanced Analytics Resource Center. So why am I mentioning this? I mentioned that there's quite a few grants looking at bridging strategies. And what we did with those grants is we looked at the ERIC strategies that they're using. And And we did it in two areas: training and education, and coaching and facilitation. And with the training and really the way we looked at it was, most of these grants started with some kind of training and education, and then progressed into coaching. But however, it gives you an idea of, around training and education, what I consider some of these more progressive programs here in the United States are doing. I mean, they develop and distribute educational materials, no surprise there. Conducting outreach visits, one of them is doing that. And these different letters are from a framework called the Epis Framework, which I'll talk about later, which E is exploration, P is preparation, planning, and I is implementation, and S is sustainment, and we have no S's here. But yeah, it gives you an idea. There's education materials, there's preparing champions, there's outreach, there's use of train the trainer in one of them, and a learning collaborative in one of those. And where a learning collaborative is when we bring multiple organizations together and sort of provide training simultaneously for them. Okay, so I mentioned the Epis approach. This is another in the notion of typologies. This is another approach. It's that's used quite a bit, and it describes the sequencing that typically happens when an evidence-based practice is being implemented. There's the exploration phase, where things are beginning to be explored. There's the preparation, implementation, and sustainment. And here's on your screen. There's a chart that I think does a pretty good job of describing it. Now, the Epis framework was developed by Greg Ahrens in 2011. There's that resource there, and what Beacon did a good job of, and what they call the J.J. Datz trials, which is a major initiative here, criminal justice initiative here that was occurring 5 to 10 years ago, is they describe these different phases. And the exploration phase is really getting the research sites, I'll use that term for this group, getting them engaged and doing initial needs assessment. And then there's the preparation. Usually that involves this training I was describing, and developing goals and implementation plan. And then really for the research I like to do, there's implementation phase, where they're actually implementing the evidence-based practice that they're trying to make occur. And then lastly, there's a sustainment phase, and which I'm really glad this is here. In a lot of models, that's typically not there. And in research we've done here, we found about 50% of the time, changes that are made in organizational settings are not sustained. Okay, so a little bit more on the Epis framework, and this is one we actually put together for one of the projects we were doing in implementing MOUD, and actually in treatment settings, and it gives you an idea of just the different pieces of it. And for those doing implementation research, these are good areas to be aware of, and it's a fabulous typology, to use that term again. You can see in the exterior, that's where you have the exterior circle, in black, is where you have the exploration, preparation, implementation, and then sustainment. And then in the middle, which is really, really important, is you have, an appreciation that outer context is very important. What's going on in the environment with regulations, payments, you name it, just community pressure and outreach is that piece. They call something the bridging factors. There's different pieces for it. There's a whole area of implementation science research where we become very interested here. We're around what they call purveyor and intermediary organizations, where you have either government groups or government funded groups that are working to implement things across the network. And so you have sort of this third party that's there helping the government and or the treatment providers. And then going back to diffusion of innovations and things like that, the innovation factors. And then where a lot of our work gets focused is in inner context. There's just around leadership, what's going on in the organization, staff's involvement, and the use of data. So there's the Epis framework for you as an implementation typology. It's the prevalent one that I'm seeing in criminal justice settings and here in the United States at the moment. Going back to some of the things people are doing around consultation and technical assistance within NJCOIN. And why I bring this up is we did a study here at the University of Wisconsin in the Chess Center, looking at different ways these purveyor organizations or external technical assistants could help people adopt new practices and make changes. And when we looked at those, we found that we looked at things like in-person training, learning collaboratives, webinars, and then coaching and consultation. We found coaching and consultation to be certainly was the strongest strategy. And so within these JCOIN projects, these are the different things people are doing to provide consultation. When they capture and share local knowledge. So what they're doing is they're going in, interviewing people, and hearing what some of the barriers are, what are some of the opportunities, and sort of providing that information back to them. Similarly, doing a needs assessment too of where the opportunities are. Providing ongoing consultation, that's a high leverage approach, and facilitation both. It goes back to even within behavioral, cognitive behavioral strategies and the like. With Miller's work with motivational interviewing, he started out with doing a lot of training. And then it wasn't until he linked training and consultation that he started to see the better results, or facilitation, either one, where you're really working with people over time. And then, and then you can see there's a variety of other things people are doing as well. And so, and so here, just some of the strategies. And again, these are from these ERIC strategies across the top here. There's 73 of them. These are the 1, 2, 3, 4, 8, 9 that we found to be most prevalent. And even these first 4, I'd suggest providing focus to. Okay, I think I've talked about that. So let's talk about performance improvement. And so what we have with the ERIC model and what we have with the Epis model, great, two good acronyms, is ways to describe what's happening. But there's really not a lot of focus within those frameworks of how to improve things. I mean, if from an implementation standpoint, with injectable naltrexone, buprenorphine, evidence-based practice, according to what I was sharing earlier, is to have those in jail settings. And I think they're right now in jail settings, that's about, here in the United States, that's happening about 10 to 15% of the time. So, okay, it's great. We can sort of talk about the different things people are doing to implement there, but are they improving on that percentage? And even with those who are providing MOUD, are they improving on that percentage? And this is where we get into the performance improvement. It's why the implementation science field was developed, is appreciating that gap between practice and implementation. And it's when the field was developed, it was appreciated. It's very hard to do. And as people have, a lot of people have been getting into this work, there's an appreciation that it's hard to do. But let's sort of talk about ways to approach it. Within criminal justice, there's this piece called the Cascade of Care. It was developed actually in the HIV arena with us. I first got exposed to it from the director, the president of your organization, Kim Johnson, and what it describes is how things are happening in sort of a sequential manner to get people from having an addiction to getting medications, treatment medications, and other kinds of treatment in a criminal justice setting. And the same cascade can be used in treatment settings as well. Where you start on the left, you have intake, about 100% are intake, of course, and then what percent are screened? 78%. That's actually of the different bars here. That's pretty good. There's an assessment in need. You can see that the numbers here are above 50%, but we certainly have a ways to go. And then a lot of people referred, a lot, 63% initiate, which is actually this research is probably a little better than I've seen in practice, truthfully. And then when you do retention, the numbers start to drop pretty precipitously, and then you get to continuing care. And when you think in terms of each one of these, that line keeps getting lower and lower, right? I mean, if you look at this 100% and you look at the 23%, you can see that there's a lot of drop off there. So from an implementation science perspective, or performance improvement perspective, there's some huge opportunities here. One thing we've done to address the performance improvement piece is develop this thing called NJCOIN, and it's a performance improvement model. It builds off a work that's been done around some plan, do, study, acts and things like that. The research I was telling you about earlier, we did do a research of different ways to apply this model around learning collaboratives, where it's just a multi-organizational effort that happens over 6 to 12 months typically, and where there's training involved and coaching. Just coaching, that was one arm of a trial we did in this NIATEX 200. We did just conference calls, that was another arm. And then what we found with these different arms is that coaching had the strongest effect, followed closely by a learning collaborative. So when you're doing your implementation piece, like I was saying earlier, coaching and facilitation are two models that you should rely on. We have a trial right now around implementation science and MOUD and criminal justice for criminal justice populations. It has 3 aims. One is to increase MOUD use in jails. The other is increase SUD intakes post-release. And then lastly, increase MOUD use post-release. And if you go back to the Cascade of Care, you can see we're sort of picking a few of those bars there that we want to leverage. And because of the evidence says these are for reducing opioid use, overdoses, and deaths, and just opioid use disorders in general. These are 3 evidence-based aims and practices. In our trial, we appreciate the importance of coaching, and so we're trying a high dose and a low dose coaching approach. We also are combining with that something called ECHO, and I'll talk about that a little bit here, in a little bit here, which is a case management training approach to clinicians. And it's a 2x2 trial where we have high dose and low dose across the top, and then we have echo and no echo. And so there's going to be four arms to this trial. We're going to have 48 sites in the trial, and we're going to have 12 sites in each arm. And sites will be jail settings or community-based settings. Okay, moving on. The Epis Framework. This is for the coaching. We're going to use this. This was a project that's been started out with funding from the Criminal, Robert Wood Johnson Foundation and SAMHSA, and we've ran it. It's been used in at least 3,000 organizations. A fair amount of that is due to a campaign and effort that Kim Johnson, the president of your organization, was behind. And really, what do we do in the Epis Framework? First of all, if you want to learn more about it, there's an online present. You just type in Epis and you'll get to it. But really, the essence of it is we ask people to have to set up projects for implementation or improvement, and where we talk about key roles, having an executive sponsor and a change leader. We talk about tools that are helpful, doing some walkthroughs and flow charting, things like that. Talk about PDSA cycles or pilot test. We find that to be really helpful and sort of, gradually improving things rather than trying to do the best approach and hope it works. And then lastly, like I mentioned earlier, the role of coaching is really important. Okay. And let me see. For Epis, we have our latest count. We're near 40 peer-reviewed publications on the Epis process. One in particular that focused on drug court use is the Epis, using this model, reduced wait times and increased treatment admissions post-incarceration from 92 to 100%. I think a decent part of that was by reducing the wait time issue, and as you might expect, the no-show rates went down considerably in treatment because of more people getting there quicker, and some of the things that they did within the trial to make it more appealing for people to return, and so that's probably what we're proudest of is reducing those no-show rates from 41% to 18%, and that's an evidence-based practice is providing treatment for. Within the trial, I mentioned that Epis is one part of it in the coaching. It's one of the stronger performance improvement implementation approaches. Something that's coming up, and it mostly focuses on the organization and organizational systems. What with MOUD, what we're sensitive to is systems change and some of these process improvements that NIATEC stuff doesn't quite get at, clinician buy-in and physician buy-in. And so what an emerging practice there is this, what we call the Extension for Community Healthcare Outcomes, or ECHO. And this one, it was launched in 2003, but really its work and use has been more recent. And what you do is you have what they did is they combined really two things that really make this successful. One is they use this video technology like we're using today, or even this conference calls, and then they also so what would happen is once a week, once a month, depending on the frequency, physicians would get together on one of these shared platforms, and then a physician from the group or an expert, what have you, would provide a case presentation around a given subject, the subject of focus, and then for about 10-15 minutes, and then after that, there'd be a discussion of the case. And what really is helpful with MOUD is that there's just a whole group of physicians that are like, we'd be glad to do this, or we'd like to expand on it, but we're really not confident about our ability to do that because we received very little training in this in medical school, and since then we just really haven't been exposed to it, and we're worried about malpractice. And so what the ECHO does is gives them a chance to build their confidence in providing these kind of services. And there has been a good trial around MOUD in New Mexico that's reported by Camerooni. And then also there's a pretty good trial around using ECHO in criminal justice settings for actually hepatitis treatment and prevention. So it's a good approach. In the Cascade of Care, one of the main items there is the transition. The transition from justice system to treatment. We've done quite a few trials around that. One trial we've done that I'm going to go through pretty quickly here is one looking at going from detoxification, or what we call withdrawal management, to treatment, and really looking at what we often call tongue-in-cheek the handoffs. And so here, in our typical detox centers, about 27% receive follow-up care. We did a project here in Wisconsin where we're using this NIATEC approach to work on getting better transitions between. We did it with 6 detox centers. It included 50 plus discharges here in the state, and it's reported just recently published in the Journal of Behavioral Health Sciences under my authorship. The community partners were a good mix of Milwaukee was in Madison, were 2 larger cities. Stevens Point is a medium size, and then these counties were in smaller areas. What we talk to people about is a bundle of doing warm handoff, short wait times, and sender-receiver communication, and using a checklist to keep an eye on that. We, using sort of a NIATEC sort of general approach, we had a kickoff meeting followed by coaching. In the research design, we had 4-month baseline, and then we did a little run-in to the trial, and then we had 10 months of data, and then did a pre-post design. It was found to be pretty representative, except the study populations had more males than the general population, detox population in Wisconsin, and more diversity due to the Milwaukee participation. In the results, we're looking at successful transition from detoxification to continuing care. This is a breakdown by the size of the municipalities. And if you look at the far right, when we started this, it was about 20% were making the transition. And then we completed it was about 43%. And so more than doubled, and really did it by looking at those issues that we mentioned. When we did analysis of the different approaches, we found warm handoffs to be very important. Around the communication, we looked at continuing care. Did it inform the referral agency? And we found that was significant. Did the continuing care, were they informed of detoxification attendance? And we found that to be significant. And then also the detoxification unit documented attendance. And these were just all, we really, and that was part of our project, was getting these two groups together and sort of working on a joint aims and project. In the logistical regression, the continuing care in informing the referral site was by far the highest, and then documenting it once it occurred was important, and warm handoffs was important as well. Earlier wait times, we didn't see that being helpful, although I have to say in other research that has been. So I think that's one we have to report we need to report the findings, but would definitely not remove that from the approach until we've done some more research. So in summary of just sort of implementation science and the things I was talking about, with implementation science itself, I think sort of where a lot of progress and energy has been applied is with these typology models. I think the ERIC strategies and Epis are really two good approaches right now, well recognized and regarded. They are necessary. I think one of the things the field is lamenting right now is when people do talk about successful and unsuccessful performance improvement kind of things, it's hard to tell exactly what people did. And so I think with these typology models, it gives you a better idea of what they did, because the language becomes more consistent. But again, it's necessary, but certainly not sufficient, and which is very similar for those of us in implementation science, very similar to training, right? It's hard to get a practice to change without training, but usually if you just do that versus doing coaching and facilitation, you're going to have challenges. What really the field needs to do, and really hopefully researchers like you will do, is just to help us have a better understanding of the impact of implementation science strategies on performance and change. And really, once we get into an international audience, and even local here in the United States, is so some of the impact of cultural issues and things like that on the approach. And I think that's actually an area needed in research too, is just a better way of sort of creating some typologies around culture. So having said those things, it's been a pleasure to talk to you today, and I will stop and we can open it up to questions.
Thank you so much. That was excellent. I see we have some of our different audience members seem to be from areas like the Philippines and the Middle East, so that's really exciting. Thank you for drawing this group and being interesting and important and relevant. One question we have is, what do you think is most important to translate from implementation science to education and practice?
Oh boy, that's a big question. I think, I mean, really the essence of the field is did you, it's really a lot about, here's the research, and the research says you should do this practice and or practices, and are you doing it? And so I think, that's at the essence of it, is how have you done in doing that? And then I think from there you can back into some of these, what I call typology models of what did you do and how. And that becomes really important, because really, from a bigger picture, what you want is, in a small scale, to be able to say, okay, these are the sequence of steps we did to be able to implement this practice. And really, in saying that, appreciate a lot of the research creates a set of structures that are often not the way things are in practice. So you have to, in a lot of the trials here in the States, there's even sort of you do the research part, and then you do a bit of a prototyping part afterwards of just, okay, if we're going to get this out, how are we going to do this? And often you start with, okay, this is how we do it in 1 or 2 or 3 sites, and then how do we, what we call scale it up from there, and or at the very least just create a bit of a guide of, this is the different steps that need to be taken. And in that guide, there's, the whole fidelity question. And I think that's something as researchers we have to keep in mind is, okay, when we talk about fidelity, what's truly needed for it to be, to have some fidelity, and is there some room for adaptation? And what's helpful in the research that you're doing is if someone's not doing it with fidelity, is there certain things when they don't do it really does, create some problems. Right. Sorry for a little bit of a long-winded answer, but you got me on the soapbox there.
No, it's important. We have a question from Ghana. What is MOUD?
Okay, thank you for that. Yeah, it's medications for opioid use disorders, or an addiction sometimes, and previously they've called it medication-assisted therapy. Basically, they're pharmacotherapies for people who have addictions to either pharmaceutical, opioids, or heroin.
And a few people are asking about the presentation. So both the presentation and the slides will be available. My email, ILESC, EYLESC @ICUDDR.org is in the chat, or in the next day or two, you can go to our website at ICUDDR.org, and you'll find both the recording for today as well as the slides are in our resources, and we encourage you to check that out. Do you know, Doctor, of any possibilities for international research that looks at cultural issues?
Not offhand, but there needs to be.
Yeah,
there needs to be, because even, just to give a small example, here in our country, we this NIATEX model has worked very, very well in most situations. And really what the model does is it says, one of the things it does is it says, okay, develop an aim of what you want to do, and then develop these PDSAs or these pilot tests to test different things and use data to sort of to see how you're doing. When we had, like I said, at the point this happened, we probably had 20 plus peer-reviewed publications. We took that to our Native American cultures, and they were like, no, we can develop aim at some point, but we really just need to sort of talk about this and sort of work through, why we want to do this, and in sort of Western, I'll call it Western thinking, and at least we do in this country. It's like, oh, you just say what you're going to do and tell everyone, and then you just do it. So,
Yep.
and I think, there's that, and then even with this medication issue, there's certain cultures that prefer not to use medications, or prefer certain types of medications. So I think, just how things get rolled out and the practice itself, I think there's just so much to be learned there. And I think, something that just occurs. I mean, and we're you've probably heard in the news, we're talking about this a lot in our country right now, or even more. I mean, in our center, we've really had a strong emphasis around cultural competencies because of this issue. But I think some typologies to understand culture and its impact on implementation, I think is really needed, and would be a great service for the field.
Yeah. Do you think that there is anything different in implementation in the criminal justice system as opposed to healthcare or other industries?
A lot of it's the same. What we are finding in criminal justice is you have what I would call some hierarchical issues that are even stronger than in non-criminal justice setting. So what's that mean? We say you should have an executive sponsor or someone who, in top leadership that's supporting it. So that's the case everywhere. But we can see in hospitals and some in treatment organizations and clinics a lot, where changes can be made without the president or the executive director, approving them, or even saying they should be considered. And in criminal justice settings, I mean, the warden or whoever really needs to be behind it, or it's really not going to move forward. And I think too, I think it's a cultural issue, and probably a necessity, is they really need to have sort of a tight, tight overview of policy and rules. And so, that's one difference. It's a little, versus like, saying, hey, let's have this group over here and come up with a bunch of stuff.
Yeah.
And the executive signs off on it. It doesn't happen as much. I mean, we do have a drug court project occurring in Atlanta where, the warden and the staff, we get all together and we come up with changes. So I think that there can be this more group kind of approach to things, but you really need top management's very important in that setting, even more.
Well, and as you say, I think, it's a subculture, right? It's a different culture. I worked in treatment facilities that were Department of Corrections funded, and we had probation officers on site, and our aims weren't always the same. So, that you run into that, and that when you're at core, not necessarily trying to do the same thing, you're gonna hit some conflict. So,
yeah.
Well,
and I think some of that, what you do is when you're going into the setting is sort of when, you talk about needs assessments and things like that, is just get an idea of as much as you can what you're walking into.
Right, and how hopefully your work can be helpful, even if maybe some of the core goals aren't the same, if it's punitive versus rehabilitative, but maybe it helps with control, or, something that is important to the corrections. So
Yep.
There's ways to make it work for sure, but it can be tricky. Well, thank you so much. We're about to round out our time, but I'm so grateful for your presentation, your time, and thank you all for the great questions. And with that, we will wrap up. Thank you, Todd.
And thank you, and hope to get a chance to work with some of you. That'd be really neat. So, and you know, as you can tell, this whole area is a huge interest of mine. So, appreciate you being involved this morning, afternoon, or evening for wherever you are.
All right. Thank you all. Take care.
Thanks, Gary.